Hi, this is Filippo Simona and Feliciana Mena from the Pax Eye Center in Locarno, Switzerland, between the papilla and the chiasma. We wrote this paper with the precious help of Ramona Guatta, Michael Reinert, Emanuele Pravata, Lucia Danieli, and Claudio Gobbi. In this presentation, we will like to invite you to an excursion in the little frequented area because it is on the borderline between ophthalmology and neurosurgery, the part of the optic tractus that goes from the fissura orbitae to the optic chiasma. We will doing it using a fil rouge, a case of one of our patients that has resolved beautiful. The optic nerve or cranial nerve, too, is not a true cranial nerve, but a fiber tract of the brain formed by axons of the retinal ganglion cells, which become myelinated by oligodendrocytes as they leave the optic disc. The optic nerve can be divided into four segments: intraocular, intraorbital, intracanalicular, and intracranial. Today, we are particularly interested in the part that goes after the optical channel, intracranial part, runs on the base of the skull and reaches the chiasma. The optic nerve is surrounded by the meninges, which form an extension of the subarachnoid space containing cerebrospinal fluid. This extension communicates with the suprasellar cistern. Therefore, pathologic conditions involving the subarachnoidal space may easily spread along the intraorbital optic nerve. Professor Clara Landau, an internationally renowned neuro-ophthalmologist and former head of the eye clinic at the University Hospital of Zurich, has been a very good friend of mine for many years. She is an excellent doctor who combines intellectual curiosity with love for her patients. Let's listen to her.
Optic neuropathy is a medical problem that usually is difficult to be treated and usually cannot be treated at all. But there are some important exceptions to this rule, and I'd like to mention these. One of them is chronic compression of the optic nerve. And in this instance, of course, you have to relieve the compression whenever possible before irreversible axonal death occurs. Another exception is an optic neuropathy caused by some toxic agent or by poor nutrition. And here, of course, either you have to remove the toxic agent or to recreate the metabolic balance needed. And this has to occur again before an irreversible death of optic nerve axons occurs. The most common optic neuropathy, the one caused by inflammation, actually due to demyelination, it has a favorable visual prognosis even without treatment, and we know all about it since the optic neuritis treatment trial. So whether you treat or not, usually the vision will recover. And on the contrary, ischemic optic neuropathy has still a very poor prognosis. We still do not have an effective treatment, even though some trials have been going on for many years, but as of today, there is no effective treatment for IOM. And to mention one very exciting optic neuropathy in the sense that treatment may be on the horizon, that's Leber's hereditary optic neuropathy or dominant optic atrophy. These are hereditary diseases, and there has been some progress in establishing treatments, but it's not yet being applied really and in the broad sense. Again, we cannot overstress the importance of making an early diagnosis of lesions that compress the retrobulbar optic nerve, meaning that in every case of an otherwise unexplained visual loss, we have to perform correct neuroimaging of the whole visual pathway, especially in the instances when the optic disc actually looks healthy. Actually, in these instances, the prognosis for visual recovery is best because the optic disc is still pink and does not convey the message of an irreversible axonal death of the optic nerve. The pathophysiology of visual recovery after surgical decompression of the anterior visual pathway is very interesting. It has been described to occur in 3 stages. The first one is a very rapid improvement, which may occur within hours, and this could be explained by a direct relief of a conduction block of the axons. It is really fascinating how quickly this can occur. I remember from my fellowship, we used to visit patients the day after their neurosurgical intervention and check their vision at the bedside in the ICU. And they clearly, many of them had already a very impressive improvement of visual function. Then comes stage 2, which is a delayed recovery, and this may take weeks. The hypothesis is that this represents remyelination of previously compressed axons, which regrow their myelin sheath. And not always, but sometimes, a stage 3 comes, which is a late recovery that may take months to years, and the mechanism is not really known. And it's a little bit unclear whether this really occurs, whether this is just something where the psychophysical examination becomes better just because the patients got used to their visual loss and are better at performing the visual examination. If you're interested, there is a old but very interesting reference to this theory. Nowadays, we have a very good tool to predict the prognosis for visual recovery after a decompression, and that, of course, is OCT. And if you're interested in this subject, I can warmly recommend this very comprehensive review and very recent review on this topic in the current opinion of neurology of last year by some very renowned authors. This is a way to predict the visual outcome, and of course, what you cannot always predict is how good the neurosurgeon will be able to efficiently remove the compression of the optic pathway. But having a very good neurosurgical team, you can provide the neurosurgeons with an estimate of the potential of the visual system in this particular patient to recover. Thank you very much for listening.
Here we report the case of a 67-year-old man that comes to our praxis for sudden decreased vision in his right eye since 10 days. He denies any specific trauma or previous ocular pathology. He refers to take aspirin cardio, antihypertensive, and cholesterol-lowering drugs. He denies smoking and refers to drink 2 glasses of wine a day and to eat regularly. The best visual acuity with correction was 0.15 in the right eye and 0.5 in the left eye. The eye pressure was normal, and at the anterior segment a bilateral mild corticonuclear cataract. At fundus photo we can see a well-delimited optic papilla, with normal color, not edematous, not excavated. High-definition OCT shows a normal foveal profile and no alteration of retinal layers. Macular cube software shows a bilateral reduced macular inner retinal thickness. Also, ganglion cell complex analysis shows a bilateral loss of retinal ganglion cells.
The quantification of the layer is automatic. Compression of the anterior visual pathways results in progressive thinning of the retinal nerve fiber layer, RNFL, and macular ganglion cell complex, GCC. The RNFL and macular GCC have been found to highly correlate with visual function in patients with compressive optic neuropathies. Preoperative RNFL and macular GCC thickness have emerged as the most reliable and consistent prognostic factors for visual recovery after surgery. Patients with an otherwise normal neurophthalmic examination, including automated perimetry, may have macular GCC or RNFL thinning as the only manifestation of compression, enabling compressive optic neuropathies to be diagnosed at an earlier stage and managed accordingly. Let me now make a very brief excursus which may be stimulating for the presentation. On 13 March, I received in my email inbox via the AAO a lecture by Dr. Gupta of Halifax with a catchy title that OCT is a lifesaver. The patient in question had experienced a decrease in eyesight. Dr. Gupta noticed bilateral nasal nerve cell layer thinning, and subsequent investigation had concluded to an aneurysm of the left carotid artery. Now back to us.
OCT of optic nerve shows the optic disc size of the right eye in the normal limits, with a reduction of the thickness of parapapillary nerve fibers, and a smaller optic disc in the left eye with a bilateral temporal defect of the retinal nerve fiber layer. We can evaluate three-dimensional map of optic nerve heads from en-face deep down, and we can observe the optic nerve head's appearance from different angles in accordance to rotation parameters. This figure demonstrates that there are no alteration of the shape of the optic nerve heads. The visual field examination shows a total visual field loss in the right eye and multiple scotomas spread mainly in the upper sector in the left eye. With angio-OCT, we also analyze the perfusion index and the flow index. The perfusion index expresses the percentage of the analyzed grid area that contains vessels compared to the total area. The flow index analyzes the perfusion of capillaries weighted by the intensity of the flow signal. In this case, they are slightly decreased in the upper and lower sectors.
The pathology is unequivocally bilateral. Visual fields are not typical for chiasmatic compression. There is no edema of the papilla, nor atrophy of the papilla. The patient denies smoking or high alcohol consumption. No symptoms of vitamin deficiency B12 and not recent operations. A neurological examination took place on March 5th. The neurological examination was normal, except for complete anosmia and ophthalmological symptoms. The patient's daughter referred to have noticed his dad more irascible in the last weeks. The examination of the visual evoked potentials is suggestive of a conduction dysfunction along the visual pathway bilaterally. Greater on the right, the curves appear flattened. A RMI is requested. The MRI study by Dr. Pravata demonstrates a conspicuous extra-axial expansive lesion with dural attachment to the ethmoid sphenoidal plenum. High-resolution images show significant mass effect of the meningioma on the intracranial prechiasmatic segment of the optic nerves. On 9th April, a neurosurgical removal of the meningeal tumor is carried out by Professor Reinert and Dr. Guatta. Here the video of the operation. Here, the description of the different anatomical elements. The improvement of the visual field has been incredibly important and unexpected. In the PV post-op examination, we note increased amplitudes with a tendency towards renormalization. Olfactory test 2.5 months later and 5 months later reveals total and irreversible anosmia. The post-op RMI shows a subtotal resection of the meningioma. There is a degeneration of the fibers of the chiasma due to the compression. Here, the optic nerve decompression. According to several large retrospective case reviews of olfactory groove meningioma, some of symptoms are anosmia and personality changes. Interestingly, our patient also reported symptoms of anosmia, and although he did not report psychiatric or personality changes on initial history, it was found that family reported irascible personality changes over the previous weeks. At the 1-week follow-up after surgery, the patient reported being able to see better, no signs of nystagmus, pupils normally reactive. The neurological examination was normal. On the subject of the analysis of post-compressive retinal axonal damage, let me present this patient of mine reviewed in March 2021 who in 2009, following a trauma with a large intracerebral hematoma, suffered direct compression of the optic nerve with irreversible papilla atrophy. Focusing on the image on the fibers around the optic nerve, it can be seen that on the left, due to atrophy, they are completely absent. The study of RNFL and GSL-IPL complex is very interesting, where on the left you can see the very clear decrease in thickness. And now back to the patient of our presentation. 1 year later, we rechecked the patient at the level of the nerve fiber to analyze a possible recovery of the thickness. In terms of false coloring of the peripapillary fibers, no difference is noticeable. RNFL and GCL-INL complex thickness analysis shows no recovery. No change in the PanoScan map of the right eye either, nor of the left eye. Data from the literature agree with our analysis. After intracranial surgery, there is no change in NRNFL and GCL-INL complex, even in patients with excellent visual recovery, as in our case.
A brief discussion about the chronic optic nerve compression. Neural relationship of the optic nerve. The optic nerve is divided into 4 parts: intraocular, intraorbital, intracanicular, and intracranial. The intracanicular part in the optic canal and the intraorbital portion of the optic nerve are enclosed by dura and arachnoid. The subarachnoid space surrounding the intracranial part of the nerve extends forward from and communicates with the subarachnoid space around the intracanicular and intraorbital portion of the optic nerve, like illustrated in the figure B and D. A brief overview of chronic optic nerve compression. Vision loss related to skull-base pathology is a common and disabling symptom. The most common pathologies in this region causing chronic optic nerve compression are pituitary tumors, meningiomas, and craniopharyngiomas. Surgical decompression is usually the standard of care because the tumor close to the optic nerve cannot be irradiated without putting the nerve at risk. Most patients, around 60%, will have at least some improvement in vision after optic nerve decompression for chronic compressive neuropathy. Ophthalmologic factors, duration and severity of vision loss, and characteristics directly related to the tumor, like histopathology, are likely most important in determining vision outcome. In the literature, the physiopathology of recovery of vision loss after optic nerve decompression is essentially explained by two hypotheses. Hypothesis 1. Optic nerve compression by an extrinsic lesion has been postulated to cause atrophy of ganglion cell axons with mechanical disruption of axonal transport. The hypothesis 2 is that optic nerve compression can cause ischemic lesions that slow down neuronal flow and disrupt axonal transport. But other acute compressive pathologies such as a trauma and pituitary apoplexy likely have different recovery characteristics than chronic compression caused by an acute ischemia of the optic nerve.
Olfactory groove meningiomas originate near the anterior cranial base, most commonly at the cribriform plate of the ethmoid bone, planum sphenoidale, and the frontosphenoidal suture. The incidence of olfactory groove meningiomas is approximately 80 till 14% of all intracranial meningiomas. Olfactory groove meningiomas are slow-growing tumors, often bilateral rather than unilateral, but asymmetrical in growth. They may produce progressive compression of the frontal lobes and project backward toward the sala, and if large enough, they can affect vision by compressing the optic nerve and chiasma. Because olfactory groove meningiomas extend posteriorly, this extension can cause compression on one or both of the optic nerves or the chiasma, and may occur earlier in smaller tumors arising from the posterior half of the cribriform plate. Compression injury to the optic nerves may induce optic nerve heat edema and eventually progress to optic atrophy, and can also present as a Foster-Kennedy syndrome. The mechanism of injury in olfactory groove meningiomas is due to the large size of the tumor, creating a downward pressure on the nerve and chiasma from above, unlike a suprasellar meningioma, which elevates the chiasma, thereby patting the crust fibers on stretch and causing a bitemporal hemianopsia with optic atrophy. OCT has become an important part of the neuro-ophthalmic assessment in these cases by quantifying the RNFL and macular ganglion cell complex thickness and providing a comparison with a healthy, age-matched population. Recent findings indicate that OCT is an important tool in the evaluation of patients with compressive optic neuropathies, particularly for prognosis in patients with visual field defects and diagnosis in patients with preserved or mildly reduced visual function. Anatomical changes detected by OCT may precede visual loss and allow for early diagnosis and presumably better visual outcomes. Preoperative OCT RNFL thickness has emerged as the strongest and most consistent prognostic factor. Of course, OCT quantification of the nerve fiber layer is usually applied in the diagnosis of compressive damage due to glaucoma, as in the case illustrated here, where increased papillary excavation is evident, but OCT has also proved very valuable in the detection of retrolaminar pathologies. In this interesting article from 2003, Coty and others analyzed the ability of the optic nerve to recover after a damage due to increased pressure on it. When pressure is applied to a nerve, conduction in individual fibers may be blocked in at least 5 ways: by hypoxia, by depolarization caused by accumulation of potassium ions and possibly other metabolites, and by entry of calcium into the exoplasm, by disruption of the cytoskeleton, by demyelination, and by exotomy. Depending on the pathogenic mechanism, recovery times are very different. These beautiful electron microscope images show the normal optic nerve, top left, a total demyelination, top right, and at the bottom a partial remyelination after 52 days. We hope with this presentation to have convinced you that the quantitative analysis of the superficial retinal nerve fibers by OCT should be a compulsory part of the current neuro-ophthalmological examination, and not only in cases of suspected increased intracranial pressure. The importance of this case report is that it provides an illustration of the optic nerve damage and visual loss that can occur with insidious tumors, such as an olfactory groove meningioma. These slow-growing giant tumors can encompass the entire anterior skull base, causing minimal symptoms such as personality changes and anosmia, but the most significant presenting symptom can be vision loss. Ophthalmologists should be aware of these olfactory groove meningiomas because they can be successfully treated surgically and prevented from becoming life-threatening.